I'm inviting Kimberly Frost to speak on the topic viral load coverage among children living with HIV under 5 years of age in USAID-supported health facilities in 11 high-burden countries. Welcome.
Thank you. Thank you very much for inviting me here to give this talk. We have nothing to disclose. In 2020, children living with HIV under 5 years of age accounted for just 1% of people living with HIV, but a whopping 11% of AIDS-related deaths globally. The 12-month probabilities, both of AIDS and of death, are higher in children with high viral load at baseline and are also higher for younger children at every level. The viral suppression rate for children living with HIV under 5 in USAID-supporting district sites at the end of 2021 was 75%, lower than any other 5-year age group. And we know that timely viral load testing is critical to identifying patients who are not virally suppressed and thus at higher risk of HIV-related morbidity and mortality. So the objectives of our study are first to describe the viral load coverage in children under 5 years of age versus those 15 and older in USAID-supported clinics in 11 high-burden countries during a 3-year period from 2019 to 2021. These are the first 3 years for which these data are available for children under 5 using PEPFAR data. Second, to summarize the barriers and facilitators to high viral load coverage in this population, as described by our colleagues working in the field and by USAID implementing partners. Routinely collected PEPFAR program data were analyzed for calendar years 2019 to 2021. Children with at least 500 children under 5 years of age on ART in USAID-supported sites by the middle of the calendar year 2021 were included in this analysis. USAID-supported sites in these 11 countries included over 40,000 children under 5 who were on ART, representing over 90% of the children under 5 on ART in USAID-supported sites at that time. Viral load coverage was calculated using PEPFAR's standard proxy viral load coverage definition. The numerator is the number of ART patients with a viral load test documented in the medical or laboratory records within the past 12 months, and the denominator is the number of patients on treatment 6 months earlier. The results were disaggregated by patient age. Viral load coverage rates for children under 5 were compared to adult rates each year, both overall and by country. Barriers and facilitators to viral load testing were extracted from the narratives that accompanied the numeric results and from presentations at PEPFAR planning meetings in early 2021 using a standardized data extraction form. Results were supplemented through additional consultations with field staff and with review of strategic direction summaries. Overall, the viral load coverage rate for children under 5 in 2021 was 61% versus 73% in adults. Pediatric under 5 coverage was 58% in 2020 and 59% in 2019 versus 72% and 78% in adults. Viral load coverage trends by 5-year age band show higher coverage in older pediatric and adolescent age groups and in adults relative to younger children, suggesting that children under 5 are uniquely disadvantaged relative to all other age groups. Viral load coverage dropped for all age groups in 2020, possibly due to the COVID pandemic. In 2021, coverage had not recovered to 2019 levels in older children or in adults, but had improved slightly in children under 5. Overall, viral load coverage trends by country and by age showed substantial variation in children under 5 and in adults. Kenya and Zimbabwe reported very poor coverage, both for young children and for adults in 2021. Kenya had major commodity stockouts in 2021. Zimbabwe, unfortunately, has had a funding gap for viral load commodities for several years. In contrast, Uganda reported very high viral load coverage both in adults at 90% and in children under 5 at 88%. Eswatini and South Africa had the largest gaps between pediatric under 5 and adult coverage, 48% and 23% respectively. Malawi was the only country to report higher viral load coverage in children under 5 at 73% than in adults at 63%, possibly due to Malawi's restricting of policy of limiting routine facility-based viral load testing to pregnant and breastfeeding women and children during the COVID pandemic. The viral load continuum starts with demand creation and continues through specimen collection, specimen transport, specimen processing, results return, and clinical management. It's a very complicated system, and for high performance, every piece of this needs to work. Breakdowns can and do occur anywhere along the way. Most viral load coverage barriers described by our partners were general and not specific to children. All predated COVID, and all were reportedly exacerbated by COVID. Likewise, most viral load coverage facilitators were general and not specific to children. These are not new, although some of them, such as the various interventions to improve access, were scaled up significantly in response to COVID. Additional viral load coverage barriers for young children were primarily related to patient factors. Children are dependent on caregivers for access, and some caregivers either don't understand the importance or don't have the resources to provide support to the child. School schedules often make clinic attendance difficult, as does lack of disclosure to the child and or to other family members. In addition, there were health facility performance challenges with sample collection, including providers who lack experience in drawing blood from young children and lack of pediatric-specific phlebotomy commodities to do so. Labs sometimes process plasma samples first, in addition, because DBS requires additional steps prior to processing, which sometimes leads to longer turnaround times for pediatric results. Since the primary barriers identified for young children were related to patient factors that impacted access to care, the most promising facilitators also addressed patient access. In many places, COVID led to a rapid expansion of community and home-based services, including community viral load sample collection. This had a dramatic impact on patient access, especially for patients like young children who traditionally had difficulty reaching care. In this model, viral load sample collection is done via home visits and visits to locations such as community ART pickup points. Samples can be collected by clinical staff, community health workers, or OVC providers, and can be either whole blood or DBS. At least 9 country programs plan to implement this strategy in COP22 at various levels of scale. Some of them, including Nigeria and Uganda, the 2 countries who reported the highest viral load coverage in children under 5 in 2021, are implementing it widely now. About 70% of children under 5 on ART in these 7 countries are currently enrolled in OVC programs. Programs for orphans and vulnerable children can continue to evolve to better serve at-risk children with HIV, both by strengthening the integration between facility and community, so things like joint case conferences and care plans, better case management, and benchmarking in some places for viral load coverage and viral suppression. Also by delivering more services, including viral load testing, at patient homes and in their communities. COVID also led to a rapid expansion of DSD and MMD models, including in children. Family-centered DSD models that include viral load testing have been implemented in Kenya, Nigeria, and South Africa, among other locations. Each of these has shown improved viral load coverage and suppression in children. Coverage of these models, however, is still evolving. Kenya's promising Papa and Mama Care model has been adopted nationally. Another common problem in implementing viral load testing in young children is providers' lack of experience and or a lack of appropriate supplies to do pediatric phlebotomy in young children. Butterfly needles have smaller needles and a butterfly device in which the needle is connected to the collection tube by soft catheter tubing rather than directly. This makes it much easier to draw blood from children, and the smaller EDTA tube means that less blood is needed to fill the tube. At least 4 countries are planning to procure pediatric phlebotomy commodities through USAID this coming year. Other countries may still do so or may be procuring these through other mechanisms. DBS specimens are easier than venous blood specimens to collect from infants and young children. At least 8 out of 11 countries plan to implement DBS viral load in children next year. Following the success of point-of-care EID, several countries have been rolling out point-of-care viral load testing for pregnant breastfeeding women and are now extending that to children. At least 10 of the 11 countries reviewed here plan to implement viral load coverage, viral load POC testing for young children in 2023 at some level of scale. Point-of-care viral load requires venous blood, so country plans should also include pediatric phlebotomy supplies when implementing this. The study includes routine program data for over 3 full years in USAID-supported sites with over 40,000 children under 5 on ART, but it has several limitations. PEPFAR's viral load coverage indicator is a proxy measure and may over or underestimate true coverage. Countries and partners vary in the ways that they collect and report the viral load coverage data, which may lead to bias in results reported by country, by age group, or over time. And quantitative information to support the specific interventions that are discussed here is relatively sparse and was not included in this review. Overall, in 2019 through 2021, children under 5 were substantially less likely than adults to receive timely viral load testing, despite their increased risk of HIV-related morbidity and mortality. Several promising strategies to improve viral load coverage in young children were described here. These strategies are primarily about improving patient access and providing patient and family-centered care. Going forward, it will be critical to track the speed, coverage, and fidelity of the scale-up of key interventions, and especially to use M&E, quality improvement, and other strategies that we know work to identify and address any persistent barriers to program implementation or to impact. Thank you to everyone who contributed to this work.